Amenorrhea refers to the complete absence of menstrual bleeding. It is classified as primary when a girl has never experienced menarche by age 15 or by age 13 if she has normal breast development, and as secondary when regular cycles that had previously occurred cease for at least 3 consecutive months. Recognizing whether the amenorrhea is primary or secondary guides clinicians toward the appropriate differential diagnosis and highlights the importance of protecting long-term health, including bone mineral density, cardiovascular function, and future fertility potential. Primary amenorrhea originates from genetic or anatomical defects that prevent the normal development of the reproductive tract. Classic examples include Turner syndrome 45X. The single X chromosome leads to streak ovaries that cannot produce estrogen, resulting in absent puberty and a small non-functional uterus. Androgen insensitivity syndrome, complete AISXY. The body is genetically male, but peripheral tissues cannot respond to androgens, so external genitalia develop as female, while the internal reproductive organs uterus upper vagina are absent. Imperforate hymen or transverse vaginal septum. A physical blockage prevents menstrual blood from exiting the vagina, causing cyclic pelvic pain without visible bleeding. Kallmann syndrome. A congenital lack of GnRH secretion from the hypothalamus leads to absent puberty despite otherwise normal genital anatomy. These conditions are usually identified early in adolescence because growth, breast development, and secondary sexual characteristics do not follow the expected pattern. Secondary amenorrhea develops after a woman has previously menstruated and can be grouped into several categories. Physiologic, pregnancy, lactation, or natural menopause are the most common and benign reasons. Endocrine, thyroid dysfunction, hypo or hyperthyroidism, hyperprolactinemia from a pituitary adenoma, and polycystic ovary syndrome, PCOS, are frequent hormonal causes. In PCOS, excess androgens and insulin resistance lead to chronic anovulation. Structural intrauterine adhesions, Asherman syndrome, after curettage or large fibroids can obstruct the outflow tract. Systemic or medical, eating disorders, anorexia nervosa, excessive athletic training, chronic stress, systemic illnesses, inflammatory bowel disease, and certain medications, antipsychotics, hormonal contraceptives, suppress the hypothalamic pituitary ovarian axis. Each cause has distinct clinical clues that help steer the diagnostic workup. The menstrual cycle is orchestrated by the hypothalamic pituitary ovarian axis. The hypothalamus secretes gonadotropin-releasing hormone, GnRH, in a pulsatile fashion, stimulating the anterior pituitary to release follicle-stimulating hormone, FSH, and luteinizing hormone, LH. Follicle-stimulating hormone promotes ovarian follicle growth and estrogen production. A mid-cycle luteinizing hormone surge triggers ovulation, after which the corpus luteum secretes progesterone to prepare the endometrium for implantation. In primary amenorrhea, the cascade may be interrupted at the very beginning, deficient gonadotropin-releasing hormone release, as seen in Kallmann syndrome, or at the ovarian level, non-functional ovaries in Turner syndrome. In secondary amenorrhea, disruptions can occur at any point. Elevated prolactin inhibits gonadotropin-releasing hormone. Excessive androgens in polycystic ovary syndrome alter follicular development. Premature ovarian failure reduces estrogen output, or physical obstruction blocks menstrual outflow. Primary amenorrhea is relatively rare, affecting roughly 1 to 2% of adolescent girls worldwide. By contrast, secondary amenorrhea is far more common, with prevalence estimates of 3 to 5% among women of reproductive age. The condition peaks in teenage years and early adulthood, particularly among individuals with low body mass index, high-intensity athletic training, or underlying endocrine disorders such as thyroid disease or PCOS. Geographic variations exist, reflecting differences in nutrition, cultural practices, and access to healthcare. The hallmark of amenorrhea is the absence of menstrual bleeding, but additional findings help differentiate the underlying cause. Primary amenorrhea may present with no breast development, indicating estrogen deficiency, sparse or absent pubic hair, low androgen effect, short stature, or a lack of secondary sexual characteristics, as seen in Turner syndrome. Secondary amenorrhea, women often report a previously regular cycle that has abruptly stopped. Accompanying features can include significant weight loss, acne, and hirsutism, suggestive of PCOS, galactorrhea, hyperprolactinemia, pelvic or abdominal pain, uterine adhesions, and infertility concerns. Physical examination focuses on Tanner staging, body habitus, and a thorough genital inspection to identify outflow obstructions. History and physical exam, detailed menstrual chronology, growth patterns, weight changes, stressors, medication use, and a focused genital exam. Laboratory studies, baseline serum levels of FSH, LH, estradiol, prolactin, TSH, and possibly anti-Mullerian hormone, AMH, to assess ovarian reserve. A karyotype is ordered when a genetic abnormality is suspected. Imaging, transvaginal or transabdominal pelvic ultrasound assesses uterine size, endometrial thickness, and ovarian morphology, for example, polycystic appearance. Brain MRI may be indicated for suspected hypothalamic or pituitary lesions. Specialized tests, hysterosalpingography or saline infusion sonohysterography, evaluates uterine cavity integrity. Endometrial biopsy is reserved for older women with abnormal bleeding to rule out hyperplasia. The combination of clinical data, hormone profiles, and imaging leads to a definitive diagnosis. Amenorrhea is broadly categorized to streamline evaluation. Primary amenorrhea divided into congenital, for example, Turner syndrome, AIS, Mullerian agenesis, and acquired, rare, such as post-radiation ovarian failure. Secondary amenorrhea sub, classified based on the dominant pathophysiologic mechanism. Anovulatory, no ovulation despite estrogen exposure, for example, PCOS, hypothalamic suppression. Hypoestrogenic, low estrogen states from ovarian failure or central hypogonadism. Outflow obstruction, physical blockage of the uterine cavity, for example, Asherman's syndrome, large fibroids. Functional, stress-related, weight-related, or exercise-induced suppression of the HPO axis. These groups help clinicians target investigations and therapy. Management is cause-specific. Hormone replacement therapy, HRT, indicated for Turner syndrome, premature ovarian insufficiency, or hypoestrogenic states to support bone health and induce secondary sexual characteristics. Thyroid replacement with levothyroxine normalizes TSH in hypothyroid patients, restoring menstrual regularity. Hyperprolactinemia is treated with dopamine agonists, cabergoline or bromocriptine, which reduce prolactin levels and resensitize GnRH pulsatility. In PCOS, weight reduction, metformin, and ovulation induction with clomiphene citrate or letrozole improve fertility. Surgical correction includes imperforate hymen repair, hysteroscopic adhesiolysis for Asherman syndrome, or myomectomy for large fibroids. Lifestyle interventions such as adequate caloric intake, balanced nutrition, moderated exercise, and stress reduction techniques are essential for functional amenorrhea. When fertility is desired, ovulation-inducing agents, assisted reproductive technologies, or oocyte donation may be employed depending on the underlying pathology. Preventive strategies aim at early identification and mitigation of risk factors. Routine pediatric and adolescent well visits, should chart Tanner stage progression and the age of menarche. Screening for thyroid disease, eating disorders, and excessive athletic training in at-risk populations. Educational programs in schools and primary care settings that encourage girls to report missed periods promptly. Promotion of balanced nutrition and appropriate exercise regimens to avoid hypothalamic suppression. Early detection allows timely intervention, reducing the likelihood of long-term complications such as osteopenia or infertility. Prognosis varies with etiology. Reversible causes, for example stress-related, thyroid dysfunction, hyperprolactinemia, often respond well to treatment, with return of normal cycles and preservation of fertility. Genetic or structural anomalies, Turner syndrome, absent uterus, are irreversible for natural conception, but hormone therapy can maintain bone density, cardiovascular health, and sexual development. Untreated amenorrhea increases risks of osteoporosis, cardiovascular disease, and psychological distress. Ongoing follow-up is essential to monitor bone mineral density, lipid profiles, and mental health. The past decade has seen rapid progress. Genomics colon-whole exome sequencing has identified novel mutations in genes such as FOXL2, NR501, and DX1 that underlie previously idiopathic primary amenorrhea. Pharmacology colon-selective estrogen receptor modulators, SERMs, and novel insulin sensitizing agents are being trialed for ovulation induction in PCOS resistant to standard therapy. Minimally invasive surgery, advanced hysteroscopic devices now enable precise adhesiolysis with higher reproductive success rates and fewer complications. Biomarkers anti-Mullerian hormone, AMH, is increasingly used to estimate ovarian reserve early, facilitating prompt action for functional amenorrhea and guiding fertility counseling. These advances promise earlier diagnosis, personalized treatment, and improved reproductive outcomes.